Hi, my name is Christopher Moreno. I'm a pathologist and clinical director of the liver unit in Hôpital Erasme from the Université Libre de Bruxelles in Brussels, Belgium. And it is my pleasure to summarize you our paper entitled Intensive enteral nutrition is ineffective for individuals with severe alcoholic hepatitis treated with corticosteroids. So as you know, alcoholic hepatitis is a clinical syndrome characterized by a recent onset of jaundice in patients with ongoing alcohol abuse. In its severe form, defined by a MADRE discriminant function above 32, the disease is associated with a poor, shortened prognosis. The European and the US guidelines for alcoholic liver disease recommend the use of corticosteroid or pentoxifylline in patients with a severe form of alcoholic hepatitis. However, regardless of the therapeutic strategy, current available treatments are unsatisfactory with a 6-month mortality which remains very high. In severe alcoholic hepatitis, several studies have highlighted that protein and energy malnutrition is present in almost every patient and is associated with impaired survival. The European Society for Clinical Nutrition and Metabolism guidelines recommend a daily energy intake of 33 to 40 kilocal per kilogram of body weight. However, these objectives are often difficult to achieve in clinical practice, and therefore the use of a feeding tube is strongly recommended if patients are not able to maintain an adequate oral intake. One study comparing 28 days of total enteral nutrition to corticosteroid therapy in patients with a severe alcoholic hepatitis show that these two approaches result in comparable survival rates. However, the possible complementary effects of combining enteral nutrition to corticosteroid treatment have never been tested in a randomized controlled trial. Moreover, the optimal energy intake to target in severe alcoholic hepatitis patients remains currently unknown. Therefore, the aim of this randomized controlled trial was to evaluate the impact of corticosteroid plus intensive enteral nutrition therapy compared to corticosteroid therapy alone on 6-month prognosis. Our study is a multicenter randomized controlled trial performed in Belgian and French hospitals, and patients with a biopsy-proven severe alcoholic hepatitis were randomly assigned to 1:1 ratio to receive both intensive enteral nutrition using a feeding tube for 14 days and methylprednisolone at a dose of 32 mg per day for 28 days in the intensive arm, or a conventional nutrition and methylprednisolone at the same dose and for also 28 days in the control arm. Daily energy and protein intake was recorded by a dietitian for 14 days, at least 3 times a week for both groups. The primary endpoint of the study was mortality at 6 months after initiation of therapy, and a total of 136 patients were enrolled in the study, 68 in each group. There was no significant difference in the cumulative risk of mortality at 6 months between the two groups in the intention to treat analysis. There was no significant difference in the incidence of hepatorenal syndrome or in the occurrence of at least one infection during the study period between the intensive enteral nutrition arm and the control arm in the intention to treat analysis. A post-hoc analysis was performed according to the percentile distribution of daily energy intake. And interestingly, regardless of the allocated therapy, patients with a daily calorie intake less than 21.5 kilocal per kilogram of body weight per day, so in the lower tertile, had a significantly higher cumulative risk of 6-month mortality compared to those with a daily calorie intake of more than 21.5 kilocal per kilogram per day. In the multivariable analysis, low daily calorie intake, platelet count, serum sodium, presence of encephalopathy, and the MEL score were identified as independent prognostic factor associated with 6 months mortality. In our study, tolerance of the feeding tube was an important issue. Premature enteral feeding tube withdrawal before the 14 days of intensive enteral nutrition was reported in nearly 50% of the patients, and serious adverse events considered related to the enteral nutrition were reported in 5 patients in the intensive arm. So, in conclusion of our study, systematic intensive enteral nutrition using a feeding tube in corticosteroid-treated severe alcoholic hepatitis patients did not increase survival. However, a low energy intake was associated with an increased risk of mortality and an increased risk of bacterial infection. And this finding therefore strongly suggests that early identification of insufficient energy intake and an adequate nutritional support should be targeted in this population of alcoholic hepatitis patients with a deleterious short-term prognosis. I thank you for your attention.